Hello, and welcome to our webcast. I'm Amy Pendergrass with Moss Adams, and I'm going to get us started for today's session, CMMI's Vision of Future Payment Models and Value-Based Care. This is the second session of our 2021 Healthcare Executive Webcast Series. More information on our conference and sessions are available in the links provided in your console, as well as on mossadams.com. Before we begin, I'm going to play a brief video.
Welcome, and thanks for joining us. We're pleased to present another in our ongoing series of continuing professional education webcasts to help companies and individuals conquer challenges as they plan for what's next. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement, or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget to the right of the slide view. You can ask our presenter questions during the webcast by typing a question in the Q&A window below the slide view and clicking Submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key.
Today's webcast is eligible for 1.5 CPE credits per the National Association of State Boards of Accountancy. To qualify for these credits, you must attend for a minimum of 75 minutes and respond to at least 5 of the 6 polling questions. Also, the presentation you are about to see isn't legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances. And now I'm going to turn the floor over to Brian Connor, the Hospital National Practice Leader for Moss Adams. Brian, the floor is yours.
Great, thank you, Amy. Appreciate the introduction and welcome everyone, and thank you for joining our Moss Adams 2021 Healthcare Executive Webcast Series. As Amy mentioned, I'm Brian Connor, the Hospital National Practice Leader and MC for our conference series. It's our 26th year hosting our annual conference. That's amazing to think about. And this year we're welcoming over 1,400 attendees from across the healthcare continuum. This year we welcome many newcomers to our series, as well as many of our honored clients and longtime professional associates. And we continue to convene executives and members of the C-suite in healthcare, from providers to payers to life science to tech, private equity, as well as this year many employers. We have lots of employers in our audience this year, and employers as major players and payers in the healthcare ecosystem. You're obviously very invested in the current and future state of healthcare, concerned about the current rising costs of healthcare, the impact it has on recruiting and retaining employees, as well as impacting their overall health and well-being. So in our virtual webcast series, we've decided to shorten it this year to 3 high-impact sessions. We've also made this year's event complimentary to say thank you to all of those in the healthcare industry who've endured 18 months of the global pandemic and the subsequent consequences of that pandemic. Last week, we had a great start to our conference series as we kicked off the series with Industry State of the Union by Ford Coles of the Advisory Board. During that session, Ford identified 6 potential structural shifts on the horizon for the healthcare industry, and 30% of our audience said that value-based purchase is their highest priority structural shift. So the stage is certainly effectively set for our discussion here today. We cannot see you, obviously, but we do welcome your participation and encourage you to submit questions throughout the session. We will do our best to answer those questions and get to them as time allows, but your participation is critical to help us deliver an engaging, thought-provoking virtual conference. And as with each of our webcasts, this program is going to be recorded and available for registrants on demand after the event. So we have a great lineup here today, and I'm excited to introduce them. Before we get to that, we do want to get to some polling questions here right out of the gate to get everybody warmed up. For all you CPE lovers, we're going to do 3 polling questions here to help you get your continuing professional education at the beginning, and then move into an uninterrupted discussion here with our panelists, and then close out the session with the final 3 polling questions. So our first polling question, this is the easy one. This is the only easy one this time. What type of organization do you represent? So I can see many of our audience have already started to submit answers. A, payer or health plan. B, physician or medical group. C, hospital or health system. Ancillary provider, etc. Pick the radio button next to your answer and then click submit. You will need to scroll down potentially. If you don't see a submit button, scroll your screen down and it should be at the bottom of the slide. And we'll give our audience just a few more moments and see what the makeup of the audience looks like this afternoon. All right, well, we have a pretty good group of, pretty good broad spectrum of audience here today. Some representing the payer community, the physician community, lots of health systems out there. So a really diverse group, I think, which is great. And you all will benefit from the discussion that we have here today. Let's move to our second polling question. Since the Center for Medicare and Medicaid Innovation was established under the Affordable Care Act in 2010, how many alternative payment models has CMMI tested to date? And if it's not obvious, we have parenthetically noted to choose your best answer. So we have 4 answers here. A, 12 models. B, 32 models. C, more than 50 models. Or D, more than 75 models. I'll give you a hint. CMMI has been pretty active since the Affordable Care Act. And just as a reminder, in order to qualify for CPE credit, you must answer 75% of the questions. We have 6 questions total, so by my math, you have to answer at least 5 questions to qualify for credit. Let's take a look at our results. Representation in all 4 categories here, but the majority, or plurality maybe, got this right. The answer is C, more than 50 models. So congratulations to those that picked C. Just so you know, you don't have to get the right answer to get credit. You just have to answer. And let's go to our final polling question here before we introduce our moderator and panel and get into the discussion. Since the Center for Medicare and Medicaid Innovation, CMMI, was established under the Affordable Care Act in 2010, about how many patients in total have the models tested by CMMI reached? A, 5 million, B, 13 million, C, 28 million, or D, 72 million. And again, your CPE certificate, for those that qualify, will be emailed to you along with the materials related to the program and a recording of the webcast subsequent to the conclusion of our presentation here today. I'll just give you a few more moments. And again, if you don't see the submit button, scroll down on your screen. It should be at the bottom of the slide deck. So let's take a look at the answers from our intrepid audience. So 44% of you are correct. 28 million is an amazing number. Patients in total, these models by CMMI have reached since the establishment of the Affordable Care Act. So now that we've gotten that out of the way, it's an absolute delight to introduce our esteemed panelists here today for our topic, CMMI's vision for future payment models and value-based care. First, I'd like to welcome back Susan Dentzer as our moderator. Susan's been a longtime collaborator for our annual healthcare conference and brings amazing insight and wisdom to so many issues that healthcare is tackling. She's a senior policy fellow for the Duke-Margolis Center for Health Policy, one of the most respected health and health policy thought leaders around. Susan's a frequent speaker and healthcare commentator, notably appearing on PBS and NPR. She has authored commentaries in Modern Healthcare, the New England Journal of Medicine, and other prominent publications. Also an editor and the lead author of the book Healthcare Without Walls, a roadmap for reinventing U.S. healthcare. And so Susan will be our moderator today, and it's great to have you again, Susan. We're also especially pleased to welcome Liz Fowler, the Deputy Administrator and Director of CMMI, part of Centers for Medicare and Medicaid Services. Liz has over 25 years of experience in health policy and health services research. She previously served as Executive Vice President of Programs at the Commonwealth Fund and Vice President for Global Health Policy at Johnson & Johnson. Liz also served as a Special Assistant to President Obama on healthcare and economic policy at the National Economic Council. Great to have you here today, Liz. We really appreciate you being here with us. And we'd also like to welcome and also are especially pleased to welcome Mark McClellan, the director of the Margolis Center for Health Policy at Duke University. Mark is a physician economist who focuses on quality and value in healthcare, including payment reform, real-world evidence, and more effective drug and device innovation. He's at the center of the nation's efforts to combat the pandemic and the author of a roadmap that details the steps needed for a comprehensive COVID-19 response and safe reopening of the United States. Mark is the former administrator for CMS and former commissioner of the U.S. Food and Drug Administration, where he developed and implemented major reforms in health policies. So for full bios, which are lengthy and impressive, you can access that on the console. But it's great to have this group here today to talk about such an important topic. So without further ado, Susan, I'll turn it over to you. The floor is yours.
Terrific. And thank you so much, Brian, for those really generous introductions. It's a sheer pleasure to be here with my friends and colleagues, Mark and Liz, to talk about this very, very important topic of the Center for Medicare and Medicaid Innovation and the movement to more value-based care. This is a complex journey, as we know, one that this country has been on really for about 20 years, if not longer, with a major, major kickstart having happened in 2010 with the enactment of the Affordable Care Act and the formation of CMMI. Some of you may have seen that old saying on posters, today is the first day of the rest of your life. Today is the first day of the rest of the movement to value-based care. So we're going to start with today and the situation that we find ourselves in today with the healthcare system as it exists today in the United States in what looks like it could be the final stages, maybe, of the pandemic, with health systems slowly recovering, not all of them, but many of them, from what we saw during the pandemic. Obviously, the immediate issues around caring for people with COVID, many parts of the country, we know that well continues. We also saw the fall off in emergency department visits, elective surgeries, and leaving many systems really still straining under the weight of all of that, as well as the ongoing need to take care of COVID patients. So we can ask ourselves how resilient the system has proven itself to be, when it's going to reemerge into a newer version of normal, and how much it will be able and inclined to engage very robustly, again, in the movement to value-based care and adoption of alternative payment models. So Liz, to take that whole set of questions first to you, give us your sense of the state of the U.S. healthcare system, the ability now to move forward in value-based care.
Well, thanks, Susan. And first, let me thank Moss Adams for inviting me to join. I'm really happy to be here and have this discussion today. And I also want to say thanks to those who've out there in the audience who were at the front lines or have been and are still at the front lines of the pandemic. The nation owes you a debt of gratitude for everything that you've given to us to keep us healthy over the last 18 months. And, you know, I think the U.S. health system is complex and diverse, and I think we saw the same with the resiliency to the pandemic. Some providers, some health systems were able to better weather the storm than others. And I would like to think that COVID may be a catalyst for value-based care, because it appears from early findings that health systems that were part of value-based care, that had made more of an investment in population health, were better able to weather that storm. And so I think we're hoping that coming out of the pandemic, there's a renewed interest in moving towards value-based care. From our perspective at the CMS Innovation Center, you know, it was a challenge for us too. The pandemic was a real obstacle for some of our models. We had to put some of them on hold. We had to delay planned model improvements. You know, some providers just weren't in a position to be able to undertake the model tests that we were running. We had to cancel downside risk for some of the models. And, you know, just generally thinking about the way that we do the models, which is to measure a baseline and then put a model in place and see what the reaction is to the model test in a comparison to the baseline. And when you don't have a baseline for, you know, much of 2020, that's what's caused some of our challenges. But again, I think we're trying to look on the bright side, and we see that the pandemic may be a positive catalyst for moving in our direction.
Great. Thanks, Liz. Mark, what is your sense, your answer to that question about the readiness of the system now as we possibly are emerging from the pandemic?
Yeah, well, first off, Susan, great to be here with you and with Liz Fowler, and great to be back with Moss Adams. Very timely meeting. I do think we are emerging from the pandemic. A couple of important steps ahead, in addition to continuing to get vaccination rates with our very effective vaccines up. First is the new oral treatments for COVID that are coming, need to be deployed effectively, and it's not so simple as just going to the pharmacy. In order to use the treatment effectively, you've got to get diagnosed, so COVID tested, and then into treatment quickly. The Pfizer very effective looking therapy was within 3 days. In addition to that, we still don't have very good control or even vaccination access in many parts of the world. So we're definitely not done with this, but thanks to the heroic effort, let me just echo Liz's comments, of everyone who's been on the front lines in our healthcare system for now, you know, a year and a half and plus and counting, we are at a point where we could potentially emerge and really get back to focusing on recovery and getting to a more resilient healthcare system. This is a big financial disruption, especially, as Liz said, for providers that were being paid on largely a fee-for-service basis. Our group at Duke-Margolis did some analyses of organizations that had moved farther away from fee-for-service prior to the pandemic. They had a pretty robust response. None of that drop in revenue that occurred for so many other organizations that were already investing in home-based care models, telehealth. So it was a question of ramping up, for example, in the case of Kaiser, from 50% telehealth visits to more like 70 or 80 at the peak. They were already taking steps like identifying their high-risk patients and having the capacity to reach them at home with COVID tests, with remote monitoring, et cetera. So from both a care model standpoint and a financial model standpoint, those organizations did better, and now's the time, as I said, to see if we can build on that coming out. Many organizations made it through thanks to supports as well as their own heroics. Supports like emergency financial relief from the federal government was pretty timely, and then a lot of flexibility in CMS regulations around where and how care was delivered, telehealth, and so forth. Susan, since then we've seen a pretty substantial recovery with elective surgery rates in most areas and elective admissions going back up close to pre-pandemic levels. Hospitals and health systems are still struggling with recurrent cases. It's not like they used to be, even though our case rates are still fairly high, lower hospitalization rates thanks to high vaccination in high-risk groups. But we haven't seen primary care fully recover. So screening tests, other vaccinations, not just COVID, colonoscopies, cancer preventive treatments, other health maintenance efforts for people who are just still, I think, reluctant to go back to the physician office, back to the traditional models, and things are definitely not fully back to normal yet. Things they can put off still seem to be getting put off. That's probably going to have some additional health consequences on top of all the downsides that we've seen with the pandemic in the United States already. A year-plus reduction in life expectancy, 3 years for Black Americans and Brown Americans, and some real gaps in primary care. So I think there are going to be some longer-term consequences here, ones that reinforce the importance of finding ways to get to a more resilient, home-based and personalized, prevention-oriented healthcare system.
Well, thanks to both of you for giving us that quick survey. And of course, now we will find out, right, whether more of the system now has gotten religion on the subject of value-based care, or whether more of the system is just going to welcome back the return of the status quo ante, and hope that continues. In that vein, CMMI recently issued, many in the audience will know, a strategic refresh white paper, looking back at CMMI's first 10 years and setting priorities for the future. And of course, that analysis entailed looking back at roughly the 6.5 years of CMMI under the Obama administration, 4 years under the Trump administration, and a little less than a year now under the Biden administration up until the present time. And in that context, CMI looked back at the models in the past, tried to evaluate what had worked, what had not, what were some of the key issues that were encountered. And because it learned so much about the transition to value, even though the results that it might be able to point to in terms of savings to Medicare and taxpayers, and the fact that those haven't been that great, and that only 4 of the models tested met the strict requirements to be adopted fully into the Medicare program, nonetheless, a lot of learning did take place, and Liz and her colleagues summarized that in that white paper. So Liz, to go to you first, well, let's talk about some of the most important lessons learned as you all set them forth in your white paper.
Well, thanks, Susan. And as you mentioned, we've spent quite a bit of time looking back at those lessons learned from the 50 models. Hopefully you got that right on the quiz. More than 50 models that we have implemented in the first 10 years of our existence. And in terms of what we've learned, I'll just run through some of our key takeaways that have informed our strategy. The first is that we can do more to think about health equity and ways to address health disparities as part of our mission to improve quality. The full diversity of Medicare and Medicaid beneficiaries has not been reflected in many of our models. So we've really gone back to think about how we're designing models to target and increase participation among the full set of beneficiaries and a more diverse set of beneficiaries than we have in the past. And how can we also increase participation among providers that care for underserved populations, and really think about equity as a measure of quality in every phase of our model. Second, I think we've really thought about how to have a more streamlined model portfolio. We've heard from providers, and many in the audience may agree with this, that our models are sometimes burdensome and complex, and sometimes they overlap. I heard the best description of the models is that they sometimes collide with each other and create a confusion in terms of who gets the shared savings for a health system that is both part of an ACO and part of the bundle payment demonstration. So moving forward, we are committed to creating a more cohesive articulation of how all the models fit together and really harmonize them and think about trying to achieve an overall vision rather than, as I like to put it, the first few years of the Innovation Center, we were throwing a lot of spaghetti against the wall. We've learned that providers need more support, that accepting risk and meeting some of our model requirements isn't easy, and not all providers have the capacity, the tools, the resources that they need to invest to think about value-based care. So we're thinking about that, how we can increase the level of support, including providing more actionable data, learning collaboratives, regulatory and payment flexibilities. We have thought about, in order to achieve broader system transformation, trying to minimize selection bias. You mentioned that only 4 of the models met the standard for what we call according to the legislation, certification. And so what we have found is that when you have a voluntary model, a lot of what happens is that providers who are better equipped and who have potentially benefit financially from the models will join, and those who don't or won't don't join. So we need to think about designing models that make it possible for a broader set of providers to join, and may also need to think about mandatory models. I think historically we've had very complex financial benchmarks that have undermined the effectiveness of our models. We set the benchmarks in the future that balance encouraging participation while sustainably generating savings. We need to think about improving the testing and analysis of benchmarks and risk adjustment methodologies prior to model launch. And finally, I think the last lesson is that we really want to be thinking about encouraging lasting care delivery transformation. What is happening on the ground? How can we make sure that what we're investing in, that our models is having a lasting impact? We have a statutory mandate related to cost and quality. We need to save money and improve quality, one or the other or both. And we'll stay true to that statutory mandate. But we haven't always thought about the experience of our models to understand what has really changed in the care delivery process and how we can do more to make sure that we're having a broader system impact.
That is a wonderful and incisive set of learnings, Liz, that you've just summarized. And I want to just home in on one of them to give Mark a chance to comment. Liz, you talked about the collision of models and the complexity of the models, particularly around the whole issue of the financial benchmarks, the risk adjustment methodologies, even the potential that you pointed to in the strategic review for some gaming and upcoding among participants that resulted in lower savings for Medicare than might have been the case otherwise. Mark, I know you've looked a lot into this issue over the years, in particular with your work with the HCP LAN. Let's talk about this whole issue, particularly around risk adjustment and gaming and so on. How much do you see that has, in fact, undermined savings to taxpayers, and what do we do about it?
Yeah, I do want to come back to that issue. Risk adjustment really matters, but let me give a couple of contextual comments first, just building on Liz's excellent summary of the past decade. I think one point that I'd like to emphasize is that to get more significant savings in models, for most providers, it's going to take some real changes and real investments in care, which is hard to do with models that are incremental, shared savings only, for example, or voluntary. We've seen some bigger opportunities and bigger successes with savings for organizations that make a bigger time and commitment to moving away from a fee-for-service structure, frees up more resources for them to spend on new care models, not depending so much on some of the services that are relatively lucrative under fee-for-service. But again, that only works if you move in pretty significantly away from fee-for-service. And understandably, to Liz's point, many organizations don't want to do that. They feel like they need to get some upfront support in doing it. So one of the successful models for smaller primary care practices gave them some of the expected savings upfront, which could support investment. The other way to do it would be support partnerships between organizations with limited capital or know-how and other organizations that could help them. And we've seen growth in that space too, with organizations that I would call value-based care enablers that provide some of the analytic and other support. But there's certainly a lot of things we've seen in the LAN efforts that you mentioned that can reinforce that, a sense that multiple payers are moving in the same direction, data sharing up front so that you know where to save. With respect to risk adjustment, I think the biggest challenge to getting savings in the model so far, Susan, has been not risk adjustment, because many of these models haven't moved tremendously far away from fee-for-service reimbursement, but two other things. One is the voluntary nature of the program. It's hard to get savings if you need to coax people to participate, especially if they need so much of this upfront help. That's not a reason not to do it. We make investments in lots of things in order to get long-term payoffs, but it does mean it's challenging in a voluntary model for organizations that think it would be a heavy lift or that are doing okay in the current system to stay where they are. And conversely, that means more of the savings that do materialize end up going in shared savings for the organizations that would participate, to entice those, especially if they might have had low cost beforehand to join. So that's a big obstacle. And then Liz did mention it, but there are some technical details here that matter. Where you set the benchmark level, how patients are attributed. And if you don't get the benchmarks right, remember we're talking about 1%, 2%, 3% savings making a big difference in how the overall savings that occurred in many more models that didn't end up with net savings, how those are distributed between Medicare and the participating providers and the beneficiaries in the model. So I think a big part of the CMMI refresh is going to be looking at how to get those aspects right. Now, with respect to risk adjustment, this is a big deal because everybody who's in healthcare knows how different expenses can be across individuals based on their health characteristics, where they live, other factors that contribute to their well-being. And we're talking about variations in expected spending of 10, 20, 30 times or more. Patients with end-stage renal disease, something 15 plus times as much as a healthy 65-year-old beneficiary. And you want to have risk adjustments so that the organizations that are attracting and especially retaining these higher risk individuals get appropriately compensated for it. But we have had some challenges in kind of getting that right. Once you shift to a payment system that depends more on risk adjustment and less on fee-for-service, more on how patients are described and coded and less on what exact traditional treatments are provided, that provides a stronger financial incentive to not miss any of those cases of mild diabetes or mild high blood pressure or other things that can make a significant difference in payments. So this is an issue that we also need to address along with the others, and I hope we can spend some more time in this session expanding on it. I think it's very important for the future sustainability and the right incentives in Medicare. We definitely need it, but we need to do it in a way that really encourages and supports the organizations that are getting the care right, not just the ones that are getting the coding right.
Right. As you say, we hope to come back to that, Mark. Thank you. So, Liz, you teed up this whole issue around the voluntary nature of so many of the models, and Mark just echoed that. And it is the case that for the most part, what CMMI has been doing is throwing a big value-based payment party, in effect, and inviting people who want to come to show up. And those are obviously, as you both suggested, going to be organizations that either are really committed to changing their business models or think they might even be advantaged somehow by doing it, but not a lot of attendance, willing attendance among those who see a threat to the current business model and think that things are going just fine in a largely fee-for-service world. And Liz, I know you've been thinking a lot about this whole notion of mandatory models versus voluntary models. And over the last decade, we had a little bit of mandatoriness, comprehensive joint replacement bundle, for example, but not a lot. And now a real question is, if we're really going to make progress to value-based payment, how much more of the mandatory thrust needs to occur versus ongoing voluntary models? So give the audience your current thinking on that topic.
Well, I'll tell you, I think there is a place for mandatory models. When I came into this job, I was convinced we needed to do a lot more of that. And I was saying so in public statements. And then the messages started coming back. You know what? You're gonna push people away, and it's gonna sound more controversial. Maybe you can tone down that emphasis on mandatory models. So I still think it's important to consider it, but I think we have to think about it strategically. So it's not just doing a mandatory model for the sake of having a mandatory model and getting people on board. It's also thinking about how you're going to harmonize what you're doing in terms of those bundles or those episodes with what are other parts of our strategy, which is total cost of care and moving people into accountable care arrangements. So I think it's not just doing mandatory models for the sake of saying you're going to get everyone in the door, but really thinking about how it fits into the overall strategy. I'll say there's actually, a couple points of, where I'd say there's not disagreement, but differences of opinion in, among my colleagues and among some of the leadership here. And that is, first of all, mandatory models. How necessary are they? The second is how necessary is downside risk? Do providers need to be at risk and see a downside risk in order to effectuate change? Again, I come at this from a perspective that I think it is an important part of broader system transformation, but not everyone thinks that. Let's have that debate. Let's have that discussion. And I think there's room for disagreement and further testing. And so that's sort of how I'm thinking about it now. I still think there's a role for it, but I'm not necessarily a cheerleader, let's say, for mandatory models, maybe as I was when I first took this role.
And Mark, you lived through not exactly this set of questions in your role at CMS years ago, but the whole notion of really effectuating large-scale change. How much do you think should be accomplished now through a more mandatory approach, or is more cajoling and inviting still probably more politically realistic, as well as potentially creating lasting change?
Well, Susan, I think you just heard in a very sophisticated answer from Liz. You've clearly been in government for a little while. Mandatory models could be a way to go fast, but it's also a way to do things wrong, and it could be viewed as very disruptive, especially for some of the more vulnerable populations that you alluded to earlier. If we aren't getting models right, going mandatory, especially big and mandatory, is a way to compound the problems rather than solve them. So I think what you just heard Liz commit to is being very clear about, and I mentioned this earlier in my answer, about what's going to make this work. Well, predictability about what the future is. If this is inevitable, if we're going to get there, then that's going to lead to more investments and more support. And Liz, that was a great effort at being clear about what the overall vision here is and how a whole series of steps are going to follow at CMS in order to make that vision a reality. Short of large mandatory models, I think of some other steps that will help. One is, remember, CMS and CMMI is doing some mandatory models right now. They're not very big around, like we're moving completely away from fee-for-service for primary care for health systems, but they are affecting components of care. Some of the successful models, kind of reinforcing this point, this is a way to get savings and care reform, included areas like reforms in post-acute care, one being implemented now. It's got some controversy around it, around radiation oncology services. Those are being tried at a regional level on a component of care and can be enlarged. Those seem to work best when there's a particular area of fee-for-service reimbursement that's just sending the wrong signal, like, kidney patients with end-stage renal disease should be getting dialysis in facilities rather than better outcomes and lower costs at home, where I think it is still a tool in the toolbox, but not probably the main or the only path forward. So I think other things that can help, again, clarity around the overall direction that CMS is heading, and then finding a path for more organizations within that to get away from fee-for-service dependence. And I do think this movement away from fee-for-service is important, especially for larger organizations. If you're a primary care group and you become a so-called accountable care organization where you can get savings if your patients reduce their total cost, well, primary care is about 5% on average of U.S. healthcare spending today and in Medicare. So that means if you prevent maybe 1% or 0.5% of the hospitalization, the unnecessary complications and ED visits in your population, you probably come close to doubling your income, and about 10 times or 15 times as much spent on those services as on the primary care. If you're a large healthcare system, and I know many that are trying to move in this direction, you can have bold primary care programs, but if a lot of the resources are still linked to the traditional ways of delivering service, not moving care out of the hospital and into the ambulatory setting or to home, and not implementing new ways for, say, specialists to work with primary care providers, even in the same organizations, to not necessarily have visits or procedures, but to have care models that really help prevent complications. That just seems hard to do without more resources that are not linked to the admissions, the procedures, more resources that are linked to enabling the specialists and the primary care doctors to work together to set up better home-based care systems, early monitoring systems. That's certainly what we've seen in the pandemic and before in many of the very successful health systems that are moving into value-based care arrangements.
Oh, well, Mark, you just laid out a lot of the really important delivery transformation efforts that are underway, and that there's a great hope more will continue. And Liz, that takes me back to you and the point you made about the desire to ensure that what we see out of all of this exercise is truly lasting care delivery transformation and truly driving accountable care. Say more about what you mean by that, and how do you judge that we are arriving at truly accountable care to enough of a degree that we really have accomplished this major structural systemic change?
Well, in our fragmented and complex healthcare system, patients who just have fee-for-service and don't have a primary care doctor or someone who is coordinating their care on their behalf probably isn't getting the best care and probably isn't getting the best outcomes. We've put a lot of our eggs in this basket of driving accountable care. And for us, in the strategy, the white paper that we've laid out, if you look, our primary goal our central goal is to get all Medicare beneficiaries into an accountable care relationship with a provider, a plan, an ACO organization that is accountable for their total cost of care and quality. And we think that this is one way to reach out to those who aren't affiliated with a provider or someone who's managing their care and try to get them that care coordination. Will this transform the system in the way that we think it will? We are betting that it will. Right now, there's about 40% of Medicare beneficiaries who are in Medicare Advantage. There's probably a legitimate question to ask whether they're getting the care management and the coordination that we envision that they should be having. But at least they're enrolled in something where there's the incentives that are aligned to manage their care. And then another 30% of beneficiaries or so are in accountable care organizations, advanced primary care models or related arrangements. It's those 30% that aren't affiliated, and those are the ones that we're trying to reach. And we think that this will that getting them into these models will increase beneficiary access to the type of care and care coordination and integration of care that we are looking for. So we've set a goal that by 2030, all Medicare fee-for-service beneficiaries and a vast majority of Medicaid beneficiaries will be in a care relationship with accountability for quality and total cost. And we're also interested in fostering greater collaboration between primary care providers and specialists in both ACO and advanced primary care models to better meet the needs of beneficiaries and take on levels of risk that are appropriate for them.
And a very worthy set of goals. All of us who have experience now with anybody in Medicare, elderly parents, what have you, know how badly needed those kinds of accountable care relationships are for so many individuals, Liz, so thank you. So I want to bring us back to the topic of advancing health equity. As you laid out, Liz, that was one of the priority goals. From so many perspectives, ensuring that equity is embedded in every one of the CMMI models, bring in more participation among providers who care for underserved populations, launch more models directly for the Medicaid population, address some of the issues of designing models that it turns out actually drive in the wrong direction around equity, implicit bias in model design, all of those issues that you've identified. But I want to take the question first to Mark, because of course Duke-Margolis has done a lot of work about thinking about equity in models. What's a meaningful path forward in this area of inducing more equity into models and achieving more health equity at the end of the models?
Let me start by saying this is super important. As I mentioned earlier, and as you all know, we've seen equity get much worse in the pandemic. We were headed somewhat in wrong directions in some of our overall population health outcomes, cardiovascular disease and deaths of despair, as they're called, before the pandemic, but that's been compounded here. And to just pick up on some of the experience to date, in the alternative payment models that have been implemented so far, they're more likely to reach Medicare beneficiaries who are in relatively high income regions. Now, for beneficiaries in lower income areas, there are often Medicare Advantage plans available, and some do participate, but that rate of having a strong primary care relationship that can really support you in all your care needs, including in many cases social factors like transportation, housing, et cetera, that are real barriers to care. That's a big gap that's gotten worse. I think the good news is there is a whole lot of attention to this issue now, including many of the organizations represented in this meeting, making commitments and taking steps. And you mentioned some of the work that we've done in this space, Susan. Just yesterday, we released 2 reviews of many of the COVID health equity commissions that states have set up around the country, and initiatives that they've undertaken to work with healthcare providers to address these issues, as well as some of the federal government steps. So a lot of that's on our website. But I think to really make progress, it's going to take not only the overall commitment that Liz described, but some intentional steps to help get there. And among those that I know are very high priorities for CMS and many of the organizations represented here is, first off, understanding just what the disparities are and the opportunities for closing gaps in quality and access within each organization's own population that it serves. Most organizations don't have very reliable data, race, ethnicity, language, other key characteristics of their populations. Many have recognized just how important place is. We talked about risk adjustment earlier. Even though they're less represented in some of the advanced alternative payment models, people who live in areas with high social vulnerability index measures tend to have significantly higher costs. That's because of more complications, things that reflect not having well-coordinated care. But perhaps it means that we need to pay even more attention to getting risk adjustment and other steps in the model design into those areas. But in addition to that, without good measures, it's hard to know what you need to improve. We've already talked about how important data is in these programs. So CMS, I think, and Liz can talk about this more, is going to make a pretty substantial push to increasing race, ethnicity data availability. It's a high priority for the Healthcare Payment Learning and Action Network, that public-private coalition that CMS sponsors on model ways to do it. I think it's probably going to be a little bit harder than just making sure that we're clear from a federal regulatory standpoint and start asking people questions to make this work. As many organizations are learning, it takes real engagement with communities at the local level. Some of that can be done regionally. That's what some of our recent reports have highlighted, accountable community efforts to engage communities and identifying top priorities for really improving health equity and reducing disparities, and then measuring them in that context, in the context of actual payment and care reforms that are being implemented to address it. So those are some of the kind of short-term, concrete, intentional steps that are going to be needed to take this unique moment that we're in. There's so much attention and desire to address these issues and turn it into an actionable path forward that's really built in, is what it started with. It's built into the CMS payment and payment reform agenda.
Well, thank you, Mark. And Liz, back over to you. Of all of these things, and Mark has just added a couple more, but the very important notion of data. But of the other strategies that you all identified, directing more models into Medicaid, making certain that more of the providers who are focused on treatment of vulnerable patients in the safety net are involved in these models. What of these strategies do you think would make the most difference to drive a greater equity in terms of the outcomes and better health status for vulnerable populations?
Well, first of all, it's hard to improve on an answer that Mark McClellan gives. So I think Mark gave a really excellent answer on some of the things that we need to be thinking about. And he's really articulated quite well exactly the issues that we're focused on. I will say, keep in mind that underserved populations and includes rural areas as well. It's not just historically disadvantaged populations. And so we see health equity as bringing in all parts of the country, all populations that haven't maybe been able to benefit from value-based care, or and so just want to make sure that to make that point that it's broader than just looking at health disparities. I think there are disparities in many parts of the country, and Mark laid out very well some of the things that we're thinking about in terms of what will work best. I will say we have done models in Medicaid. It's hard to do a model in Medicaid, because, and I think this is on our part, and I think maybe it's been a challenge for states too. We have a model, it has a lot of specifications, a lot of requirements. Sometimes states don't have the bandwidth to invest in our models to meet those requirements. So I think that's not the best way to maximize impact. We need to bring Medicaid along, but we're really thinking about bringing Medicaid along through multi-payer alignment and making sure that we have, that we're working with private payers, we're working with commercial plans, and with states as well, and moving in the same direction. So it's not a matter of come join our specific model and meet these specific requirements on our specific timeline, but really sort of, can we make sure that all oars are in the water and moving in the same direction? And that includes Medicaid as well. So I'd fall back more on the strategies that Mark outlined. The data collection, the enrollment of other providers who haven't participated, et cetera.
Well, let's stay for a moment on that question of multi-payer models, because despite the best of intentions, those have been few and far between, relatively speaking, in the CMMI sector of innovation. As we think about multi-payer models, bringing on more commercial plans, number one, and also partnering with large employer purchasers who have the potential to really drive change in the healthcare delivery system, haven't always taken advantage of that power that they have, but increasingly are alert to opportunities to do that. How do you see moving forward in a multi-payer sense on that level to effectuate care delivery transformation and truly to deliver upon accountable care?
So
Liz,
I can start. Yeah, so I'll start. And, this is another area where when I was coming into this job and getting a lot of advice from a lot of deeply respected experts, and asking how important is multi-payer alignment. And some would say, you know what, it's a lot of work. It's too hard. You need to focus your efforts elsewhere. But then some have also said, you've got to get multi-payer alignment. You've got to get other payers on board. And I think I've come down on that side. Medicare payment policy is a real catalyst for change. The health system is not going to change without Medicare playing a significant role, but Medicare can't do it alone. We really do need to be working with those private payers, with purchasers, other public payers. And I think, as I mentioned, we need to think differently about multi-payer alignment. It's not just about joining our models, which is not an easy lift. And so alignment should look different going forward than it maybe has in the past. What does an effective approach look like? I think we're figuring that out. I'd say we're building the plane as we're learning to fly. It's somewhere between broad concepts and principles and specific model specifications. So it might mean aligning on key alternative payment model design features, for example, clinical tools, outcome measures, payment, policy approaches to strengthening primary care. There's a role, and Mark mentioned the role of the Learning and Action Network, or the LAN. We work through the LAN. Mark is an important part of their leadership to launch a National Accountable Care Action Collaborative that will include recommendations on key design features as the ones I've just mentioned. We're also thinking about geographies that are best suited for innovation models, where there's like a convergence of innovation, a critical mass of partners, a willing state health authority, and other factors that might combine to make these efforts more successful. And finally, the Innovation Center can be a convener, like we're doing with the LAN, but also a potential joiner. It's possible that we borrow or build on other organization strategies, like some of them that we see out there. For example, we've been in a lot of conversations with PBGH, a large employer collaborative. It's not an approach we have necessarily used in the past, but I think it's one we need to be more creative and think about exploring alternatives in the future.
Great. And PBGH, of course, was the Pacific Business Group on Health, now the Purchaser Business Group on Health, given that it's very broad geographic representation across the U.S. So, Mark, what would you add to Liz's perspective on the importance of engaging across the multi-payer spectrum?
Well, I think it's important to recognize that, especially as we're starting to come out of the pandemic, and there's so much dissatisfaction with the gaps in primary care, the lack of care coordination, people looking ahead and seeing opportunities for earlier diagnosis and treatment of everything, including COVID, as I mentioned at the outset. This is where a lot of pressure is headed. And Liz mentioned PBGH. We're collaborating with them on some of these reforms that are very much in the same direction that Liz outlined, building in a foundation of strong primary care and accountability for cost and assistance with coordination. That's something that many large employers are doing. We're part of a partnership with Morgan Health for version 2.0 of their prior efforts with Amazon and Berkshire Hathaway to implement reforms that they're doing in their own employee groups and looking for partnerships, including like the ones Liz just described. Many states are implementing these reforms. This is core to Medicaid and now multi-payer reform efforts in North Carolina, many other states, California, Washington, Ohio, or also others are also implementing or moving towards implementing the same kinds of approaches. So So there is some growing momentum behind this, and especially for organizations that want to get out ahead on where healthcare technology and diagnostics and therapeutics are definitely headed. Now's the time to get engaged with it. And that's what we're trying to convey through these collaborative efforts like the LAN. As Liz said, that it's not about relying on every single detail. Did you set up exactly the same payment reform model and the state Medicaid program as in your major commercial plans with Medicare? It's really aligning on sort of the key features, which is we need more primary care and care coordination and ways to do that. We know models that work for that have been proven to save money in Medicare and elsewhere. We need to complement that like with what some employers have been doing around more bundled payments and centers of excellence for specialized care, and then putting that together with steps to engage beneficiaries. And that's where I think multi-payer efforts can really help. Finding some, again, not relying on everything, but relying on some key goals, slowing down total spending growth while improving outcomes in areas that matter in a state or a market, and improving access to some of these innovative care models. So those, I think, are all promising ways to go, and it also can help be facilitated by things like data sharing. Healthcare has very complex data that we're aligned on key things that we want to address. In North Carolina, we're focusing on things like top social needs of many lower income individuals, and then both Medicaid and commercial plans and Medicare. So data that can connect healthcare providers that recognize these needs to help with housing or hunger or a few other types of assistance programs. Not a huge amount of data. It's important. Connecting data from state public health systems, like on COVID vaccinations to healthcare, so you can find gaps in vaccination, identify people at high risk of complications, addressing maternal mortality and health differences, key priorities that can drive action around data, around other supports for implementation.
Great. I want to move a bit to an area that I know, Liz, you and Mark, both of you have given a lot of thought about, and it gets to the issue of collision among models and overlap among models. Not within the purview directly of CMMI is the Medicare Advantage program, which of course is within the purview of CMS. And Mark, it was certainly within your purview when you were CMS administrator.
Oh, well, yeah, we implemented it for the first time.
Right. Well, there were earlier generations of it, right? But in any case, as we now have other models coming about, the so-called direct contracting model, Liz, through the aegis of CMMI, things start to look very similar. I think you said something about this a few moments ago, where you have essentially capitation, movement away, really abandonment of fee-for-service Medicare, and looking really more at population-based payment, but in different realms. Although, interestingly, some of the same players who are in Medicare Advantage also are playing and want to play in direct contracting. As we think through that potential for overlap, what concerns do you have about that, about differentiating these two different approaches? And does it matter, or does it not matter if the world kind of converges around either a direct contracting approach on the one hand or Medicare Advantage on the other? So Liz, please start, and Mark, I'd love you to weigh in on that as well.
Yeah, well, first of all, let me just say that we view direct contracting as the next iteration of an ACO, of an accountable care organization. It's not part of Medicare Advantage. It is sort of the furthest out, pushing the envelope on some of the concepts related to accountable care organizations. So, but I do think you're asking a really important question. Right now, we're operating about 28 models concurrently. They create opposing incentives, as we've discussed. So going forward, we need to think about a set of criteria for our models. Does the model support or advance one of our strategic objectives? What's the potential impact for health system transformation? What's the likelihood of successful execution, what's the likelihood for multi-payer alignment. And then I think the question you're asking, we want to make sure that there's also, we're not creating methods for arbitrage, where you can figure out where's the benchmark in this model versus that model versus this model. Where do I want to put, more of my chips, in what region? The more you create these differentials, the more there's a chance to sort of look at gaming the system rather than having what I would think of as the ultimate goal, which is a level playing field where decisions are made based on where you it's based on care delivery. What model is best able to deliver the sort of care and outcomes that we're looking for, and it's not a matter of sort of how this risk adjustment varies from this one, the benchmark over here, the benchmark over there, how the rates are set. So we're looking at that closely. It's a complicated business, but that's, I think, I will also add that Secretary Becerra has really charged us with thinking about how to make sure that we are creating a level playing field between fee-for-service Medicare, what we think of as traditional Medicare, and Medicare Advantage. So all of these things are sort of front and center. That includes the benchmarking, that includes the risk adjustment, which we've already talked about. So all of those issues are sort of on top of our mind and couldn't say I know exactly how how this will all play out, but these are things that I spend a lot of time thinking about.
Mark, as you know, relatively recently, two preeminent thinkers in this area, Don Berwick, who of course was CMS administrator in the early Obama years, and his colleague McClellan, who was the first CMMI head after the enactment of the Affordable Care Act. Recently have heavily critiqued the existence both of Medicare Advantage as well as direct contracting, as they put it, as the pathway to Medicare privatization. And they have pointed to factors such as the charge that Medicare Advantage hasn't cost any less for the federal government than traditional Medicare. In fact, the opposite, that it is, in their view, a big money play. They are engaging, in their view, in the kind of arbitrage that Liz just referenced. How do you see this? And if it's in fact the case what do we do about it? Both from the standpoint of getting what we want to get out of these programs, which is movement to accountable care and care transformation without necessarily spending more on it. Ideally, of course, we want to spend less, or at least control the rate of growth of costs, and not necessarily create this money machine that they are talking about.
Yeah. Yeah, so it's a great question, and I'm glad you gave me a chance to come back to risk adjustment. One of those issues that sounds kind of, pointy-headed, but like really important for the financial support for care models that aren't fee for service. So Susan, as you know, and as Liz definitely knows, the crux of the argument, which was kind of an attack on Medicare Advantage and the preemptive one on direct contracting, because that's only now starting to be implemented in its first year on a limited basis. So we haven't seen the results yet. But the basic idea is that if you're in a per person capitated payment system, the risk score, the risk adjustment factor associated with that individual matters incredibly much for payment. Why? Because healthcare is really expensive, and because people's health status varies tremendously in predictable ways across Medicare. Now, we implemented risk adjustment, you know, and based on patient characteristics. Back when I was at CMS, we were really trying to get a revamped Medicare Advantage program as a private sector alternative off the ground. And I thought it was critically important then to avoid a focus on health plans signing up people who were healthier. In fact, if there ever is an opportunity for care coordination, putting together different providers, paying for things in a different way that may be hard in traditional Medicare, it's for the patients that have the more complex needs. That require a lot of, we talk about social services, and talk about home-based care, community health workers, team-based approaches to care, a lot of services that just aren't covered in traditional Medicare. And I think there are a number of organizations in Medicare Advantage that are doing this in pretty innovative ways, and we can maybe come back to that. Just things that you can't sustain financially in traditional fee-for-service. The downside, of course, is that if you can't get these codes captured, that can mean a big impact in payment, with some Medicare Advantage plans now having RAF factors for their overall population are on the order of 1.3. $1.4 times the Medicare, traditional Medicare rate on average. And there's a question in the chat about, well, aren't they discovering some conditions that were out there? In many cases, they are. And there's a lot of undertreatment, and certainly a lot underreporting in traditional Medicare. It just doesn't matter for payment, and we want, right, providers to have some support in going out and finding health problems early. The problem is that these are patients who are probably not nearly as expensive as ones who were being coded before. So it definitely has the potential to add a lot of money to Medicare, and CMS has taken steady steps over time, and I would bet Liz is going to do it, or CMS is going to do it again next year to kind of squeeze down the overall payments to Medicare Advantage to offset some of that. But Susan, what I find really concerning about this today is this is the future. So you just heard Liz saying want to move in the direction of more comprehensive person-focused models. We think they can deliver better care. There's some evidence of individual plans that are doing it well, but we don't have a very good picture systematically of just how good care is in specific Medicare Advantage plans and specific fee-for-service practices. Let alone even in Medicare Advantage versus fee-for-service overall. So you're right that MedPAC, that independent group advising Congress, has suggested that these, quote unquote, excess payments because of the RAF scoring could total, 120, 140 $40 billion over years. Well, keep in mind that is only a small fraction of the total Medicare spending in these programs over the next 10 years. So it seems like it'd be worth spending I don't know, a few $1 billion figuring out what the right answer to this question is. And it is kind of controversial. You know, some of the data that MedPAC relies on included people who are only involved in Medicare Part A in their cost comparison. They focus on Medicare Part A and B costs, keeping in mind that Medicare Part D is significantly less expensive in the MA plan. So we really need a more serious effort, hopefully quickly, at what are the total spending implications of one program versus the other, and what are the out-of-pocket spending implications? Those are definitely lower in Medicare Advantage. Medicare Advantage beneficiaries overall, they skew towards lower-income Medicare beneficiaries who, don't have nice employer supplemental wraparound coverage, and a lot of people with some ongoing chronic conditions. And then what are the health outcome differences? We measure quality in somewhat different ways in Medicare Advantage versus traditional Medicare and the alternative payment model. So it seems like for Liz to realize that goal of getting alignment between the programs, there needs to be a significant investment, hopefully quickly, in understanding quality differences. And if we really wanted to do something about these risk adjustment factors, which are very important on the one hand, but can be misused on the other, and certainly distract from the focus on just how do we make care better. If we had more objective data on these different programs and the plans and providers within them, that could be a basis for risk adjustment and for better performance measurement. So moving more of that into a third-party approach. CMS does that to a very limited extent now with their so-called HCAHPS measures and surveys that are done by independent third parties of patient experience. We've talked before about just how much difference geographic specific details like the SVI, the Social Vulnerability Index, in your census tract matters for both cost and outcomes. There's a pathway to doing more objective comparisons that could be both informative for this debate and more informative for getting alignment going forward. And I hope we can see some more progress on that soon. And just probably one final thought, and I'll put this for a while. The focus should really be on how do we get the healthcare provider systems, the delivery systems we have now, as quickly and effectively as possible into the kind of vision that Liz was outlining, where anybody that they're treating is getting well-coordinated care, they're avoiding complications, they're having a need not just met but anticipated. So for that, we definitely need a more advanced ACO program option, as it's called, and hopefully that's forthcoming soon from CMMI. We definitely could use a revamped Medicare Advantage program that does more of this alignment around the same goals that I described. But I do think there's probably a role for organizations working with providers to help make more progress. As I said, there's a lot of investment now in companies ranging from City Block Health to others that are focusing on dual eligible, complex patients with kidney disease, mental health conditions, et cetera, that can help a provider group that doesn't have these capabilities, get them faster. And if we can get more alignment and more a level playing field, hopefully that can create a good path to making all of these options available, because we need all the help we can get in making this transformation.
And you said it, Mark. You said it. Well, we're going to go now to our final 3 polling questions, and therefore bring back on stage, as it were, Brian Connor to pose those final 3 polling questions. So, Brian, over to you.
Great. Thanks, Susan. Susan mentioned let's get to our last 3 polling questions to make sure that we can take care of CPE before we turn it back for some closing remarks and possibly, time permitting, to get some audience questions. So the first of the final 3 polling questions is, how many of the alternative payment models that CMMI has tested have been shown to produce statistically significant savings to the Medicare program and to taxpayers? A6, B13, C28, or D49? And based on one of our earlier questions, CMMI has produced over 50 alternative payment models since the inception of the Affordable Care Act. And just a reminder, choose the radio button next to your answer and then hit submit. And if you don't see submit on your screen, scroll down a little bit and it should be there, but you need to hit submit to get credit for your answer. And we've got close to 80% of our attendees have answered so far, so we'll just give it a few more minutes to make sure that, a few more moments, I probably should say, to make sure we get as many of our attendees with credit as possible. And let's take a look at our answers. So we had 37% on 28, 32% on 13. You estimated a little bit high, actually. The number is 6. I think rather surprisingly, it speaks to some of the initial spaghetti on the wall that Liz had referred to, and some of the strategic changes that might be coming to these programs going forward. Interesting answers and information there. Let's go to our 5th polling question. In CMMI's recent white paper that has been discussed here, and I think we have a link to in the console, detailing its strategic refresh and future plans, which of these areas did CMMI not designate as a future priority or as a priority for future work? A focus on health equity should be embedded in every model. B, the number of models tested should be streamlined and overlap among them minimized or eliminated. C, models should encourage accountable care and lasting delivery transformation. Or D, all healthcare providers should be encouraged to embrace full risk models as quickly as possible. We have tricky polling
These
questions.
are tough, Brian.
I know. These
Close
aren't
attention.
gimmies. These aren't gimmies. We're going to make sure people are listening. It's important information. Now, we have a number of questions in the chat asking about CPE. As a reminder, we've got 6 total questions, and 5 must be answered to qualify for CPE certification and credit.
So you've at least got to get through this one, folks.
Assuming you were present and paying attention for the first 3. And let's take a look at our answers. And nice job, audience, going for D. Well done. As Liz had noted earlier, one of the areas that CMMI did not designate as a priority was to get everybody into full risk as quickly as possible. And our final polling question, a true or false question. We don't see this very often. More than half of the models tested by CMMI